Every single day, more than 4 billion people around the world sit down on a toilet without realizing they are slowly damaging one of the most delicate muscular structures in the human body. Not once, not occasionally, multiple times a day, every day, for decades. And by the time the consequences arrive, the hemorrhoids, the pelvic floor collapse, the chronic constipation, the prolapse that requires surgical repair, most people have no idea that the cause was something they did 3 times a day in complete privacy without ever questioning whether they were doing it correctly. Here is what nobody in a gastroenterology office is going to tell you in a 12-minute appointment. The way you use the toilet right now, the posture you sit in, the time you spend there, and the way you push when nothing is happening, these 3 things together are responsible for a staggering percentage of pelvic floor disorders, hemorrhoidal disease, anal fissures, and chronic constipation in adults over 50. That is not folk wisdom. That is documented colorectal physiology, and it has been known in clinical proctology for over 40 years. But your next appointment will not include a toilet posture discussion. There is no billing code for it. There is no pharmaceutical product attached to it. The system makes money when you stay sick, not when you get better, and the toilet is one of the most profitable blind spots in modern medicine. Before continuing, subscribe to Dr. Waterling right now and hit that like button. We are working toward 1,000 subscribers, and we are building this channel on one principle: telling people the things their doctor knows but is never given the time to say. Every subscriber moves us closer. Every like tells the algorithm to show this to someone who needs it. And before this video ends, write your age in the comments. The doctor wants to see which age group makes up the majority of viewers because it will directly shape what is covered in future videos. Now here is the truth that 15 years of clinical practice has made impossible to ignore. The human body was never designed to eliminate waste while sitting on a chair-height porcelain platform. For roughly 200,000 years of human evolution, every single ancestor of every person watching this squatted. The modern sitting toilet is approximately 150 years old in widespread use. The human colon, rectum, and pelvic floor are 200,000 years old. That mismatch is not a minor inconvenience. It is the silent driver behind conditions millions of adults assume are simply part of aging. Let the doctor explain exactly what is happening inside the body. There is a muscle called the puborectalis. It is a sling-shaped band that wraps around the rectum like a lasso, anchored to the pubic bone on each side. Its job is continence. When a person is standing or sitting upright, this muscle contracts and pulls the rectum forward into a kink. That kink is intentional. It is the reason stool does not simply fall out when a person stands up. The angle created between the rectum and the anal canal is called the anorectal angle. And in a standing or sitting position, that angle is approximately 80 to 90 degrees, a sharp bend, almost a right angle. Now picture trying to empty a garden hose that has a sharp kink in it. No matter how hard the water is pushed through, that kink restricts flow. The body's solution, when sitting on a standard toilet, is to push harder, to strain, to bear down with the abdominal muscles, raising intra-abdominal pressure to forces that have been measured in research to exceed 100 to 150 millimeters of mercury during forceful straining. To put that in perspective, that is higher than the systolic blood pressure of a healthy adult. Every single time a person strains on the toilet, they are subjecting the pelvic floor, the rectal veins, the anal cushions, and the supporting connective tissue to pressures the body was never designed to absorb in that position. When a person squats, however, something remarkable happens. The puborectalis muscle relaxes. The anorectal angle opens from roughly 80 degrees to approximately 100 to 110 degrees, nearly straightening the passage. The kink disappears. The hose is straight. Evacuation requires almost no abdominal effort. Research published in the journal Digestive Diseases and Sciences demonstrated this directly using defecography, a real-time imaging study of the rectum during elimination. Participants squatting completed bowel movements in roughly 1 minute with minimal straining. Participants seated on a standard toilet required nearly 3 times longer and reported significantly greater perceived effort. That is the physiological foundation. Now the doctor wants to walk through the 3 specific mistakes that, in 15 years of clinical practice, account for the overwhelming majority of preventable pelvic and rectal damage in adults. The first mistake is the seated posture itself, specifically the angle of the hips relative to the torso. On a standard toilet, the thighs sit at approximately 90 degrees to the torso. As just explained, this maintains the kink in the rectum. The fix is not buying a new toilet. The fix is changing the geometry of the body relative to the existing toilet by placing the feet on a low platform, somewhere between 17 and 23 centimeters in height, which is roughly 7 to 9 inches. The knees rise above the hips. The hip angle changes from from 90 degrees to approximately 35 degrees. This single positional change relaxes the puborectalis muscle and opens the anorectal angle. The specifics matter. The platform should bring the knees clearly higher than the hips when seated. The feet should rest flat on the platform, not on tiptoe. The torso should lean slightly forward, approximately 20 to 30 degrees from vertical, with the forearms resting on the thighs. The spine stays relatively straight. This is the closest a modern person can come to the natural squat without leaving the toilet seat. A small wooden stool, a sturdy plastic step, even a stack of books wrapped securely will work. This costs nothing or close to nothing, and it changes everything. The second mistake is duration, time spent on the toilet. This is one of the most underestimated risk factors in colorectal medicine, and the data is unambiguous. Every additional minute spent sitting on the toilet beyond what is necessary for elimination increases venous pressure in the rectal area. The anal cushions, the small vascular structures that help maintain continence, are designed to swell and shrink. When a person sits on the toilet seat with the buttocks unsupported in the central opening, gravity pulls blood downward into these vascular structures. They engorge. The longer a person sits, the more engorged they become. Add straining to that engorgement, and the result is hemorrhoidal disease, which affects approximately 1 in 2 adults by age 50. The clinically appropriate duration on the toilet is between 3 and 5 minutes. If elimination has not occurred within roughly 5 minutes, the body is signaling that it is not ready. The correct response is to stand up, walk away, hydrate, move, and return when the urge returns naturally. Sitting for 15, 20, 30 minutes scrolling on a phone is not patience. It is sustained venous congestion of the rectal cushions. In a clinical study published in the American Journal of Gastroenterology, prolonged toilet sitting time was significantly associated with both symptomatic hemorrhoids and rectal prolapse, independent of constipation status. The phone, the magazine, the moment of quiet, these habits feel harmless. They are not. The third mistake is the most damaging and the least discussed. It is the Valsalva maneuver, the act of bearing down forcefully, breath held, abdominal wall tensed in an attempt to force elimination that is not happening on its own. This is the silent destroyer of the pelvic floor. Every single forceful strain transmits pressure through the abdominal cavity downward onto the pelvic floor muscles, onto the rectal veins, onto the supporting fascia that holds the bladder, uterus, and rectum in their anatomical positions. Repeat this pattern thousands of times over decades, and the supporting tissue gradually stretches and weakens. The result, particularly in women but increasingly recognized in men, is pelvic organ prolapse, fecal incontinence, urinary stress incontinence, and chronic hemorrhoidal disease that no cream will ever fully heal because the cause is mechanical, not topical. The fix here is harder because it requires patience and discipline. When a person sits down and the body is not ready, the correct response is not to push harder. It is to wait, to breathe, to allow the natural reflex called the gastrocolic reflex, the wave of peristalsis that follows eating and signals the colon to move, to do its work. If after 3 to 5 minutes of relaxed, unforced sitting nothing happens, the person stands up and tries again later. No forcing, no straining, no bearing down, ever. Now here is where conventional medicine fails this entire conversation. When a patient arrives complaining of hemorrhoids, the typical sequence is predictable. The doctor prescribes a topical cream containing a corticosteroid and a local anesthetic. When that fails, a stronger cream. When that fails, a referral to a colorectal surgeon. When that fails, rubber band ligation. When that fails, hemorrhoidectomy. A procedure with a notoriously painful recovery. At no point in this sequence does anyone ask the patient how long they sit on the toilet, how hard they push, whether their feet are flat on the floor or elevated, what their hip angle is during elimination. The mechanical cause goes completely unaddressed, and the patient cycles through escalating interventions while continuing the exact behavior that created the problem. Patients have been told to eat more fiber, to drink more water, to take stool softeners, to use suppositories, to try osmotic laxatives, to try stimulant laxatives. And these things have a place, but they are downstream interventions for an upstream mechanical problem. A person can eat 35 grams of fiber a day and drink 3 liters of water and still develop hemorrhoids if they sit on the toilet for 20 minutes pushing against a closed puborectalis muscle 3 times a day. The position is the problem. Until the position is addressed, every other intervention is a workaround. Now the doctor wants to share a case study that illustrates this exactly. Margaret was 64 years old when she came in. She had been managing recurrent hemorrhoids for nearly 12 years. She had tried every cream available over the counter and several by prescription. She had undergone rubber band ligation twice. Her colorectal surgeon was recommending surgical hemorrhoidectomy. Her diet was already excellent. High fiber, plenty of vegetables, adequate hydration. On paper, she was doing everything right. The first question the doctor asked her was how long she typically spent on the toilet in the morning. Her answer was 25 to 30 minutes. She read the news on her tablet during that time. The second question was whether her feet rested flat on the floor or whether she had to stretch to reach. She was 5 foot 2 inches and her feet dangled. The third question was whether she pushed. She said she always pushed because nothing happened if she did not. Within those three answers, the entire mechanical picture was complete. The protocol was simple. A 19-centimeter wooden footstool placed at the base of the toilet, used every single time, a 5-minute maximum time limit enforced by a small timer set on the bathroom counter, no phone, no tablet, no reading material in the bathroom, and absolute prohibition on pushing. If nothing happened in 5 minutes, she stood up and waited for the next natural urge. Within 3 weeks, her hemorrhoidal symptoms had reduced by approximately 70% according to her own report. Within 2 months, she had not needed a topical cream once. Within 6 months, her surgeon, examining her at follow-up, told her the hemorrhoids she had once had were essentially gone. She canceled the surgery. That was 4 years ago. She has not had a flare since. Now here is the complete clinically organized protocol, step by step, starting tonight. Tonight, before bed, find or purchase a stable platform between 17 and 23 centimeters in height, a small wooden stool, a sturdy plastic step from a hardware store, or a commercially available toilet stool. The exact brand does not matter. What matters is height and stability. Place it directly at the base of the toilet so the feet can rest flat on it when seated. This costs almost nothing and lasts decades. Starting tomorrow morning, the morning protocol begins. Within 20 to 30 minutes of waking, drink approximately 300 to 500 milliliters of plain warm water. Not hot, not cold, warm. This stimulates the gastrocolic reflex and signals the colon to begin its morning motility wave, then eat breakfast. Any reasonable breakfast. Oatmeal with fruit, eggs with whole grain toast, yogurt with seeds. Within approximately 15 to 45 minutes after eating, the gastrocolic reflex will trigger the urge to move. This is the natural window. Do not ignore it. Do not delay it for the commute. Honor the signal. When sitting down on the toilet, place both feet flat on the platform. Knees should be clearly higher than hips. Lean the torso forward approximately 20 to 30 degrees, resting the forearms on the thighs. Allow the abdomen to relax completely outward. Do not suck it in. Breathe normally, deeply, through the nose into the belly. The pelvic floor relaxes when the diaphragm descends with breath. This is one of the most important and least discussed aspects of healthy elimination, the connection between diaphragmatic breathing and pelvic floor release. Stay in this position for no more than 5 minutes. Take a small timer or a watch into the bathroom. If elimination occurs, excellent. If it does not, stand up, leave the bathroom, and return when the urge returns naturally. Under no circumstances should there be straining, bearing down, or breath holding. If pushing feels necessary, the body is not ready. Trying to force a reluctant bowel is the single most damaging thing a person can do to their pelvic floor. Throughout the day, 2 additional behaviors matter. First, hydration. Approximately 1.5 to 2 liters of total fluid daily, adjusted for body size and activity level. Second, movement. The colon is a muscle. Muscles respond to motion. A 20 to 30 minute walk each day, ideally after a meal, dramatically improves colonic transit time. Sedentary people have sluggish colons. This is physiology, not opinion. The expected timeline of results is important to understand realistically. Within the first week, most people notice reduced straining and shorter time on the toilet. Within 2 to 3 weeks, hemorrhoidal symptoms, itching, burning, bleeding, swelling, typically begin to subside if they were present. Within 4 to 6 weeks, the pelvic floor begins to recover from chronic strain, though full recovery from years of damage can take 3 to 6 months. Within 6 months of consistent practice, the majority of patients in clinical experience report a complete transformation of their bowel function. None of this is fast in the way a pharmaceutical is fast. It is, however, durable. It addresses the cause rather than the symptom. Now, some important boundaries. If a person is currently experiencing rectal bleeding, particularly bright red blood mixed with stool, dark or black stool, unexplained weight loss, a change in bowel habits lasting more than 3 weeks, persistent abdominal pain, or a feeling of incomplete evacuation that does not resolve with these changes, that is not something to manage at home. That is a clinical situation requiring evaluation by a gastroenterologist or colorectal specialist. Colorectal cancer is the second leading cause of cancer death in the developed world, and many of its earliest signs mimic benign hemorrhoidal disease. If symptoms persist or any red flag appears, see a physician. Everything in this video supports normal physiological function. It does not replace medical evaluation when something requires requires clinical examination. A few additional notes on scope. The protocols described apply to functional issues: hemorrhoids, mild to moderate constipation, pelvic floor strain in adults without underlying structural disease. If a person has inflammatory bowel disease, a history of pelvic or rectal surgery, diverticulitis, or known pelvic organ prolapse, individualized medical guidance is required. These general protocols are a foundation, not a replacement for specialist care in complex cases. If a person is currently taking medications that affect bowel function, opioid pain medications, certain antidepressants, calcium channel blockers, iron supplements, or prescription laxatives, do not adjust those medications based on anything in this video. The interventions described work alongside medical treatment, not instead of it. Discuss any medication-related concerns with the prescribing physician. And finally, a word for the people who have been struggling with these issues for years and feeling embarrassed or alone. This is one of the most common categories of human discomfort in existence, and almost nobody talks about it. 40 to 50% of adults over 50 experience hemorrhoidal symptoms at some point. 20 to 30% experience some degree of pelvic floor dysfunction. These are not character flaws. They are mechanical consequences of a posture mismatch between modern plumbing and ancient anatomy. The body is not broken. The position is wrong. Once the position is corrected, the body, in most cases, knows exactly how to heal itself. This is the kind of information that should be taught in every primary care visit, in every gynecology appointment, in every gastroenterology consultation. It is not, because there is no revenue in it and no time for it in a 12-minute appointment. That is exactly why this channel exists, to share what 15 years of clinical practice has taught about what people need to hear and almost never get told. Before the video ends, please write your age in the comments. The doctor reads them. The age distribution shapes what gets covered next, and there are specific issues that affect different decades differently. Knowing the audience makes the content sharper. And if this video helped clarify something that has been quietly affecting daily life, send it to someone who might be silently struggling. A parent, a spouse, a friend who has been managing chronic discomfort and has never been told that the toilet itself is part of the problem. They may have spent years thinking this was simply aging. It is not. It is mechanics. And mechanics can be corrected. Subscribe to Dr. Waterling, hit the like button, and stay for the next video, where the conversation moves to what happens inside the pelvic floor during sleep and why so many adults wake up feeling pressure they cannot explain. That information is going to change how a lot of people understand their mornings. Until then, take care of the body. It is the only one anyone gets. And the small things, the things done 3 times a day without thinking, are the things that decide how the next 30 years feel.